Good morning. My name is Lisa Freeman, and I want to thank you for giving me the opportunity this morning to share my husband Rory's story with you. In 1991, when my husband Rory was 37 years old, he went into the hospital following an injury to his back. We had 2 young children, and surgery was recommended to prevent paralysis that we were told was otherwise inevitable. What was to have been a 6 to 7 hour operation to relieve thoracic spinal compression lasted almost 19 hours. After many inquiries trying to learn what was going on during that time, Rory was finally wheeled out of the operating room to the neuro ICU with a gray pallor from head to foot. Over the next weeks, we realized that he was paralyzed from the waist down. He had hypoxic brain damage, and he had a MRSA infection in the spinal canal, requiring a number of subsequent surgeries over the next several years. Over the following years, we also learned that a number of things had gone wrong during surgery. Amongst other things, the operation was done at the wrong levels, there appears to have been a great amount of blood lost, and the spinal cord must have been stroked. According to the surgeon on a follow-up visit, either before, during, or after surgery. But right after surgery, we were not told anything. In fact, the very short operative report essentially said that everything had gone fine, the operation was completed, the instruments were counted 3 times, and Rory was closed up. We were stunned by the outcome, and our lives were turned upside down. Rory's experience extended to many. My life was abruptly thrown off course because Rory needed 24-hour care 7 days a week. Overnight, our children lost their dad as they knew him, and they lost me, their mom, because I had to take care of Rory. His colleagues were impacted. His mom and dad had their hearts broken seeing their son so badly injured and so ill, and his friends were impacted as well. Over the next 18 years, until he died in 2010, from numerous complications of that surgery, we experienced many hospital stays because of infections that came and went, and consequential orthopedic and neurologic injuries and illness that he incurred. We saw good and we saw bad. We learned firsthand what it is that is important to patients in terms of their experience. We learned that person-centered care and being an engaged patient is not an option, but the only kind of care that makes sense from everyone's perspective. And we experienced that even when consideration was given as to what was best for Rory, we had to be engaged in that decision. During one hospital stay, when Rory had pneumonia, he had to be transferred from a medical floor to the ICU. He was wheeled down to the ICU in his bed because transfers were very challenging for him. When we arrived at the ICU, we asked the nurse if we could go over how they would transfer him from bed to bed. We had years of experience. Not only was he having difficulty breathing, but because of his spinal cord injury, he had to be handled in a certain way so that he wouldn't spasm or have other problems. The nurse firmly told my daughter and me to go to a waiting room. She knew her job and did this all the time. About a half an hour later, an ICU doctor and a medical student came out to the waiting room. The doctor introduced himself, and he introduced the person with him, the hospital chaplain. It seems that they had taken Rory's oxygen off for just the moment that it would take to transfer him. When they went to move him, they triggered a spasm, which caused the nurse's hold of him to give. She sprained her arm, and he was without oxygen for longer than he could tolerate. He had coded, and he was now intubated. Had that extra moment been taken before the transfer to go over a plan with the patient and the family, this may have been avoided. Remember, the patient is the only member of the care team who has been there the whole time and has the whole story. Communication is one of the leading root causes of sentinel events, unexpected occurrences involving death or serious physical or psychological injury. During another hospitalization, we had a very different experience. Rory was taken by ambulance to a local regional hospital that had a very person-centered culture firmly in place. He was experiencing severe back pain and other symptoms that had the appearance of a recurrence of his original spine infection. After being admitted, he was taken up to the floor. The nurse greeted us and asked how often I thought I would be there. Because his medical condition was so complex, whenever Rory went into the hospital, someone was always with him. I told her that I would be moving in with him. Imagine how surprised I was when she said, "Then we will put him in a double room so that you will have your own bed and you can get sleep at night also." I was accustomed to sleeping on a straight-back chair during most of his other admissions. Next, she let us know that his medical chart was at the nursing station. This was before electronic health records, and that we were free to take it to his room any time to see what was included and so that we could be better informed about his health care and the care plan. Furthermore, we should let her know if we needed any explanations, wanted to make any corrections or any additions. We were equal members of his healthcare team. Then came the big challenge. Rory needed an MRI. He was claustrophobic, he couldn't breathe well on his back, and that position caused his pain levels to elevate. He also suffered brain damage in his original surgery from too much anesthesia, and he was frightened that it could happen again. How were we going to do this? A team meeting was called. Rory, me, his nurse, an anesthetist, and a person from the patient relations department. We devised a plan. I would sit with the anesthetist and monitor what was going on. Rory was put into twilight and the MRI began. When I noticed his body twitching, I told the anesthetist that he was starting to feel things, and she increased the anesthesia. Then she might say to me, "His oxygen sats are going down, so I'm going to reduce the anesthesia." But I was able to see that he was doing okay. The MRI went well. There was no infection, and we avoided treating Rory with an unnecessary course of IV antibiotics, which is what would have been done without the MRI. I tell Rory's story so that what happened to him won't happen to others. I hope you will think about what each of us can do to advance patient engagement in their own health care. In fact, what can be done to engage patients at all levels and in all aspects of health care? I believe it is time to push the envelope. Patients need to be given appropriate support and education. We need to be empowered so that we can be full and equal members of our healthcare teams and our healthcare systems. Communication tools need to be further developed to support patient communication and engagement in healthcare. It is also important that when sentinel events occur, patients are not kept in the dark and only told what the healthcare system feels that they need to know. Transparency leads to unabated trust, and trust is what patients feel is one of the most important cornerstones of the provider-patient relationship. These changes represent a culture change that will only happen if there is buy-in and leadership at the top levels of our healthcare systems. This paradigm shift will only be successful if patients and their families are engaged at every level and in every aspect of healthcare, not just our own personal healthcare. What can you do to change the status quo? Thank you for your time this morning. It's very much appreciated.